operates on a fundamental principle of axial flow, which is highly efficiently used for moving fluids. The axial flow pumps blood parallel to the axis of rotation, and in context of impeller, there is a very tiny, rapidly rotating impeller or a motor, a miniature copper blade, is housed with a catheter. This impeller continuously draws blood from one chamber of the heart and expels it to the axillary artery, thereby providing a very continuous non-pulsatile blood flow, indirectly assisting in heart's pumping action. So, seeing at the components of impeller, so it has a very pigtail catheter in the end, so it helps in better lodging in the left ventricle to avoid any perforation and stuff. Then it has a blood inlet area. This part remains in the left ventricle. This is a very shaft in which there are these helix structures through which the blood circulates. This end is the outlet end, which is in the ascending aorta. It has a motor which helps in which controls the number of rotations, and it also has an optical sensor in some of the devices. So it senses the pressure in the aorta and its correct position.
So in a single rotation of the things within the pump, how much ml will be pushed up?
So this automated impeller controller is based on that. There are different levels. So based upon the devices, supposing the first device is impeller 2.5, so the maximum outflow we'll get is 2.5 liter per minute. So per minute, yes. So the rotations are set in such manner. So once we set a reference limit, the programmers select P1. The level of blood flow is labeled as P levels. So there are programs from P1 to P9. So depending upon the flow, the reference limit that we have set.
So that we can set from outside.
Yes, the reference limit we can set. Like suppose if we want 2 liters per minute. So that reference limit is set based upon the sensors which are present between like the pressure difference in between empty ventricle and ascending aorta. Depending on that, they will select the program.
Can we change also that limit after implantation? Suppose you want to increase or decrease?
Yes, after implantation it will change. So there are two types. One is the CP, then there is the smart assist, which has all the optical sensors in every ventricle as well as in the ascending aorta. So the flow charts are maintained like per second. So depending upon the pressure differential, the programs will keep on changing. And there are alarms which are set saying that the preload has reduced, so there is a chances of the suctioning of LV ventricle over. So we know that we need to increase the preload so that there is blood which needs to be circulated. Or if there is like, since we are getting a very good output and patient mostly is used in cardiogenic shock. So if the patients are on vasopressors, there will be vasoconstriction. So the afterload might increase, that also will be seen. So it will change accordingly the load and give us alarm setting. So it is like preload dependent and afterload sensitive. So this automated impeller control has waveforms. One is the arterial waveform, second is the motor pump waveform, and if there are sensors which is present, so those waveforms are there, so we come to know that if there is a displacement of the catheter or not. And there is a purge system, dextrose solution. So this is kept at a very high pressure of 600 mmHg to 1000 mg because this prevents the blood of getting into the motor of the shaft. So it is constantly at a high pressure. This is the catheter and which is being inserted. So this is the entire system of impeller. See the procedure, the insertion is through femoral artery. Depending upon the type of impeller selected, mostly it is 2.505 which requires 9 French femoral sheath. So it is typically advanced retrograde, like against the blood flow in the aorta. This usually involves getting access to femoral artery, and sometimes for the larger impellers, 5.5 or we need to have a surgical atherectomy. So in that case, it is through axillary artery. So once inside the arterial system, the catheter is carefully guided under fluoroscopic imaging. The inlet port where the blood enters the pump is precisely positioned within left ventricle, and the outlet port where it exits is in the ascending aorta. The impeller within the catheter rotates at high speed, drawing oxygenated blood directly from left ventricle. The blood is then immediately propelled into ascending aorta. So the blood goes through this cannula, which has helical structures, which causes it a rotation. So the rotating impeller pulls blood through the cannula, and the AIC controls how fast the impeller rotates. Rotation speed is proportional to the flow. Faster the rotation, higher the flow. arterial pressure. So since the systemic blood flow is increased, there will be good peripheral organ perfusion. So and as well as coronary perfusion. So this peripheral organ perfusion helps in recovery from multi-organ failure, where there is reduced perfusion in cases of hypovolemic shock or cardiogenic shock. And increasing coronary perfusion helps in myocardial recovery. Moreover, we are basically doing LV's work. So with LV drainage, we are unloading LV's pressure, which thus reduces LV workload and myocardial oxygen demand, which again helps in myocardial recovery. So these are the basic hemodynamic effects that we are searching for. So types of Impella devices, these are categorized by their flow capacity and the ventricular support. Most commonly is Impella 2.5, provides up to 2.5 liter per minute of flow. Another is Impella CP, cardiac power. This provides flow of from 3.5 to 4.0. And this is the most commonly used for high-risk PCIs. The Impella 5.0 provides 5 liters per minute of flow. This requires surgical cut down because this is placed to axillary artery. And another is 5.5 with smart assist, which has both the sensors in inlet and outlet. So that is an advance.
So what is exactly the basic difference between IABP and Impella?
IABP, sir, is basically placed, it is also a temporary mechanical support, but in IABP, the work of pumping has to be done by LV ventricle. It is going to just help during diastole and afterload after the blood has been pumped into the ascending aorta. So we are not unloading the workload of LV ventricle. We are helping in systemic perfusion with IABP, but in comparison to IABP, Impella is much better because basically the LV does not have to work. It does not have to pump, so it has a time of recovery. So the decrease in myocardial oxygen demand is more in case of an LV, this Impella, because the entire blood is being pumped from LV ventricle to ascending aorta. In IABP, the blood has already been pumped into ascending aorta, and that inflation of the balloon, deflation of the balloon is going to cause current and pressure that is going to help in systemic So first was IABP, but then much better is Impella.
Normal cardiac output is 4.5 to 5 liters per minute. So why the concept of 2.5 liters?
So this was the initial first that Impella was FDA approved in 2008 was having capacity of 2.5. Afterwards, with advances in motors and everything.
One day the LV is constantly, it must be adding to what Impella is doing.
Yes, but
That's why, maybe that.
Maybe that, but the first was 2.5, but if it was, supposing the patient is having an EF of 20%, there is not much LV contraction that is going to happen. So in that cases, we might only increase our cardiac outputs. So for that case, higher power, this was done. And Impella RP is when the Impella device is placed in right ventricle. It is usually in right ventricular failure. It provides a flow up to 4 liters per minute. See, indications. Impella devices are used in situations where heart needs temporary assistance, mostly cardiogenic shock. The primary indication, especially following acute myocardial infarction, the heart cannot pump enough blood. Second is high-risk percutaneous intervention for severe coronary artery disease and reduced EF, which are undergoing complex PCI procedures like unprotected LM or multivessel or patients requiring IVL or rota, where hemodynamic support is needed to prevent procedural complications. Second is again of shocks only, myocarditis leading to severe heart failure or post-cardiotomy shock, heart failure after cardiac surgery. Another is bridge to decision or recovery or transplant or bridge to transplant of ventricular assist devices, permanent ones. So it's used as a temporary measure while awaiting heart recovery. Contraindications of Impella, the absolute includes maintaining heart wall because the Impella cannot go through the prosthetic wall. Severe AF because the amount of blood that we are sending into ascending aorta will be regurgitated back in LV. If there is a left ventricular thrombus, because there are chances of suctioning of the thrombus. Severe peripheral artery disease, which does not allow enough caliber of the artery to send the capital. Aortic dissection, HOCM, or right ventricular failure with severe tricuspid regurgitation. That is specific for Impella. Relative contraindications include moderate regurgitation, severe coagulopathy, and severe peripheral vascular disease. The complications that can arise, one is vascular excess bleeding or hematoma because it's a very large sheet. In 2.5 and 4.5 there is a sheet of 9 French, but if you are using 5.5 or something, then we might have a larger sheet, so which leads to hematoma. There is chances of limb ischemia, again due to reduced blood flow in the same limb or like in the right side of the right side. Or there is a vascular injury which is causing arterial dissection or pseudoaneurysm. And if there is a bleeding which has been seen in retroperitoneal hemorrhage. The other hemodynamic related complications can be hemolysis. Because the blood is going through a pump, there are chances of more hemolysis, and those hemolysis can also lead to AKI due to breakdown of blood cells. Second is thromboembolism. We keep on having an Impella patient on anticoagulants, but still there are chances of clot formation. Device malfunction or displacement, aortic valve injury. Arrhythmias can happen if the pictate or the catheter is touching or triggering the myocardium, and the most severe one is ventricular suction events. So if left ventricle is excessively unloaded or if the patient becomes hypovolemic, the Impella inlet can suck into the ventricular wall, leading to alarm events, reduced flow and potential myocardial injury. Another is infection, catheter-related bloodstream infections can happen. And AKI is due to either hypoperfusion, hemolysis, or multi-organ failure can also occur. So the trials which led to this, the first trial was Recover 1 trial, 2006 to 2007. It was registered for the study of hemodynamic support with Impella 2.5 in patients undergoing high-risk PCI. The device which was studied was Impella 2.5, and the objective was to evaluate the safety and feasibility of Impella 2.5 in patients undergoing high-risk PCI. It was multi-center. The key findings demonstrated the feasibility and safety of Impella for hemodynamic support during high-risk PCI, which were capable of higher risk of MACE. So it led to the groundwork of larger comparative trials. So it was the initial clinical experience that we had with Impella 2.5. Second came the Protect 2 trial, percutaneous coronary intervention for PCI in high-risk patients. It was to compare the safety and efficacy of Impella 2.5 versus IABP in patients undergoing non-emergent high-risk PCI. It was RCT. Patients with TBD, complex TBD or unprotected left main and severely impaired LV, which was less than 35%, were undergoing high-risk PCI. The primary endpoint was 30 days of major adverse events. The trial was stopped early because there was no changes that were seen. There was no statistically significant difference between IABP and Impella in the primary composite endpoint. But in 90 days outcomes, as per pre-specified protocol analysis, at 90 days showed a statistically significant reduction in adverse events favoring Impella over 2.5. Hemodynamic support provided by Impella was much superior than compared to IABP. So, based on this trial, though it was not found that Impella is better than IABP, but there was one found that it was giving a superior hemodynamic support during high PCI. Third was it was utilizing cardiogenic shock, that was interest in severe shock trial to compare the efficacy and safety of Impella CP versus IABP in patients with severe cardiogenic shock complicating acute MI, which were undergoing PCI. It was multicenter open label. Patients with myocardial infarction with cardiogenic shock were mechanically ventilated before randomization, and the trial was a very small, considering only 48 patients, and it was underpowered. It showed no significant difference in 30 days or 6 months of all-cause mortality between Impella CP and IABP. And Impella CP was associated with higher rates of major bleeding and hemolysis, requiring device removal, likely due to its larger sheath compared to IABP. So, although underpowered to show mortality benefit, the trial provided important feasibility and safety data in a very high-risk population. It underscored the need for larger, adequately powered trials to definitely assess Impella's role in AMI and CS. This led to the foundation of Danger Shock trial. This was Danish-German cardiogenic shock trial in 2013 to 2023. It was published in 2024. It was a landmark trial in cardiogenic shock. So the question was, does routine use of Impella CP heart pump improve survival in patients with acute myocardial infarction-related cardiogenic shock compared to the standard care? So the design was again randomized controlled. Sample size was 355. 1:1 ratio was given. 179 Impella CP patients and standard care patients. This standard care patients included patients with IABP or not with IABP. Follow-up was at 6 months. And randomizations was stratified by revascularization timing and MI location, so anterior or non-anterior. And most of the patients underwent immediate PCA. So for timing, it was if the patient was randomized to Impella group, within 15 minutes the Impella insertion should be done, and the support should be minimum at least for 48 hours. Escalation was permitted in both groups, like patient could be taken for a higher blood flow, like from 2.5 to 5.0, or if there is a need for ECMO to be given. So the inclusion criteria was STEMI plus cardiogenic shock, shock defined by systolic blood pressure less than 100 mmHg or on this plus or minus on vasopressus, lactate levels more than 2.5, LVF less than 45%. Exclusion was if the shock was more than 24 hours. There were mechanical complications of MI like ventricular rupture or severe valvular regurgitation or cardiac component or severe valvular disease. If the patient is already on any kind of mechanical circulatory support like ECMO or LV thrombus or severe bleeding. The primary endpoint was all-cause mortality at 6 months. With Impella it was 48% and with standard care it was 58%. This was significant with hazard ratio of 0.74 at a p-value of 0.04. The secondary endpoints. The secondary endpoint included composite cardiac endpoints. So composite cardiac endpoints included any additional mechanical circulatory support which was required, either short or temporary, like patient had to be escalated on ECMO or something, or heart transplant, or death of any cause which came up with whatever came up first. So that was also less in compared to IABP. In Impella CP it was 94% compared to IABP. The adverse events were more in IABP in Impella compared to CP. The bleeding was seen in more in Impella. Limb ischemia was seen. Patient had to be kept on dialysis due to hemolysis in Impella, and there were chances of stroke more in Impella. So the adverse events were comparatively more. So the key takeaway for this was that routine microaxial flow pump using STEMI with cardiogenic shock reduced 180 cause of all-cause mortality, but was associated with higher adverse events. The survival benefit persisted despite complications. So it was an homogeneous population, included only patients with profound LV failure and excluding post-cardiac arrest coma, differed because excluding out of hospital cardiac arrest with GCS less than 8, treating pure cardiogenic shock not mixed with post-resuscitation shock, and avoiding GCS, since GCS is less than 8, we are excluding those patients, we are avoiding the confounding by hypoxic brain injury and retinal other drugs.
But how many days it was kept?
See, Impella can be kept for 14 days at max. So in trial, at least all the patients had Impella for more than 48 hours. Minimum was 48 hours. So 2 days it had to be kept.
So more the days, the limb ischemia.
Is the chances, yes. Bleeding, limb ischemia, anticoagulation, stroke, everything increases. So the hemodynamic support, greater survival benefits in patients with low baseline blood pressure, and this gave us an optimal condition for usage that was low afterload and minimized vasoconstriction. So it also, with the experimental data, it was found that unloading the LV, so reduces LV wall stress, reduces myocardial oxygen demand, and possibly reduces the infarct size. No data has been suggested. The limitations were, it was not generalizable to all the shock patients, like post-cardiac, post-CPR patients were not there. Hence, if the patient is having extramarital shock, we have no data. Patients with biventricular failure were excluded. The shock stage patients C without lactate elevations. So this is basically a scoring for patients with shock, has a 5-grade system, and the C stage starts when the patient requires any kind of mechanical circulatory support. But if it also shows increase in lactate elevation, so if that was not present, we had not taken. And it had a limited geographical scope and it was unblinded. So that was the limitations of the study. trial, based on this study, is the RECOVER-4 trial. It's to assess whether an Impella-based treatment strategy initiated prior to PCL in patients with stem cardiogenic shock improves survival and functional outcomes compared to non-Impella-based standard care. It's a prospective multi-center internationally randomized control trial. Patients with stem ICS with onset less than 12 hours and prior to index PCL, existing persistent hypertension and signs of impaired perfusion were selected. Implication is basically it aims to build upon the findings of danger shock and provide further robust evidence on optimal timing and role of Impella in this critical patient population. So in the latest 2025 guidelines for management.
How many participants are there in the trial?
It's ongoing. Actively ongoing.
Total participants कितना आते हैं लगे include करके?
ये सर अभी हमारा डिटेल
Clinical trial की website पर रखी हो.
trial. Coming over to the guidelines, 2025 guidelines for management of ACS, it provides a two-way indication. In selected patients with STMI with severe refractory cardiogenic shock, insertion of Impella is reasonable to reduce death. And for high-risk PCI, there is a guideline of only 2021. In that, it is a 2T indication. In selected high-risk patients, elective insertion of an appropriate hemodynamic support device as an adjacent to PCI may be reasonable to prevent hemodynamic compromise during PCI. I did not get the previous angio of this patient, but we had done an Impella insertion in an 81-year-old patient who had presented with unstable angina, and the angio was suggested was severely calcified aortic, and his EF was 30% with anterior hypertension. So this Impella insertion was done prior to PCI, and this angioplasty was IVL associated. So we needed a
cardiogenic shock.
No sir, it was high-risk PCI. It was calcified aortic. We needed an IVL assisted plasty. The patient's EF was 30, so there were high chances of patient going into hemodynamic compromise, shock and everything. So
Viability test करिए तो बिना
no sir.
highly calcified LED
Viability is chance.
implicate कई રીતે કર્યું કે આ જ છે આ ખોલવાથી ફાયદો થશે.
Can you put through subclavian?
Not through axillary artery or surgical we have to go through. There are only two approaches there. Axillary and
આનું જે અંદરનું પંપ ને બધું હોય છે કયું મટીરીયલ હોય છે? મેટલ ઓર રબર ઓર પ્લાસ્ટિક?
नहीं, pump is metal. This shaft, sheath નો છે material exact बोलेंगे, but it's a flexible sheet. The entire motor and the inlet and everything is covered with a catheter
તો
shaft.
પોલીયુરેથેન જ હશે પણ અંદરનું શું છે જે રોટેટરી ડિવાઇસ છે?
જે metal covered છે. It is motor is metal, but this metal I.
How much increase in the cardiac output?
Sorry.
How much increase in the cardiac output is actually?
So 2.5. We are basically setting the cardiac output. So it's like 2.5 or 4 or 5 inch or whatever cardiac output we have. So
3 લાખની એન્જિયોપ્લાસ્ટી જગ્યાએ 23 લાખ થાય. 20 લાખમાં ડિવાઇસ.
યુઝ એન્ડ થ્રો હોય કે આમાંથી કાંઈ રીયુઝેબલ છે?
ખબર નથી. પૈસા રીયુઝેબલ છે.
વન ટાઈમ યુઝ છે કે
One time.
20 લાખ રૂપિયાની વન ટાઈમ યુઝેબલ વસ્તુ બેન તમે કયા કન્ટ્રીમાં છો? તો આનો આ who bear the cost of this Impella 81 years આપણે આ સેન્ટર પર કર્યું ને?
Emna son was a cardiologist from US.
ઓકે. સો કોઈ કંપનીએ ગુડવિલમાં આપ્યું હતું કે
A Biomed નું જ મળે છે સર. એમનું જ છે એ રીતે કરી અધર તો પોસિબલ નથી, but this is
81-year-old કાકા 30% રિજેક્શન થાય.
diagnosis of
તો
unstable
બધું જ ચાલે.
નહીં ટાર્ગેટ 100
Yes,
years
sir, detail મને actually
તમે નહોતા પ્રેઝન્ટ આ કેસમાં?
કેસમાં હતી સર, પણ ફાઇલ્સ ને બધું
આપણે અહીંયા કરી શકીએ. અહીંયા
કેસ હોય તો એટલે જ રાખતો હતો જે પહેલા
એટલે હવે કાર્ડિયોલોજિસ્ટના ફાધર જ હતા એટલે એ મસ્ટ હેવ થોટ કે આ લીઝન છે એ બહુ મીનિંગફુલ હશે અને કાઢ્યું હશે બાકી
એમના તરફથી બહુ ઇન્સિસ્ટન્ટ હતું કે જે ડોક્ટર
એટલે જ કર્યું હોય ને નીકળ તો કઈ
યંગ કાર્ડિયો હતા
કેમ આ નથી કરતા
ત્યાંથી જ આયા હશે
ના ના ફોન પર મોટા ભાગે બધું થયું હતું પહેલા ડિસ્કશન
એટલે યંગ કાર્ડિયોલોજિસ્ટ યુએસએ માં હતા
હા ત્યાંથી બધું કહેતા કે તમે બાય યુ આર નોટ પુટિંગ ઇન પહેલા તો એકચ્યુઅલી ઘણું સ્ટોર્મી કોર્સ હતો શરૂઆતના 8-10 દિવસ અને પછી થોડું સ્ટેબલ કરી પછી 10 દિવસો પછી આ ડિસિઝન લીધો કે આને સ્ટેન્ડ કરવું છે તો દરેક બધા તરફથી મના આપણા તરફથી એડવાઇસ નથી એમ એ લોકો તરફથી
એટલે કાર્ડિયોજેનિક શોક ઇનિશિયલી કદાચ હશે તમે આવી ત્યારે પ્રેઝન્ટેશન વખતે હશે
એટલે આ 30% ઇજેક્શન ફ્રેક્શન છે પહેલેથી નહોતું
ના ના ઇટ વોઝ
એક્યુટ હતું એમ
અને આપણા તરફથી
So now the question comes: if an ejection fraction reduces, is an unstable angina or non-stable ejection? How an unstable angina can have ejection fraction of 30%?
If the injury has occurred very, like the patient has presented after 10,
પેલો કહે છે કે હમણાં આ જે ઇવેન્ટમાં હતી તમે કહો છો કે પહેલા થયું હતું આવું તો કેવું if what is a index event માં જ તમે એને અનસ્ટેબલ angina કીધું હોય અને તમારું અનસ્ટેબલ માં
એટલે એક્યુટ ઓન કોરોનરી ઇવેન્ટ હશે એક્યુટ ઓન કોરોનરી ઇવેન્ટ હશે ક્રોનિક કોરોનરી સિન્ડ્રોમ હશે એમાં એક્યુટ
પ્રોટા એબ્લેશન કર્યું તો આમાં
IVL current.
so this most likely this was a chronic lesion and the ejection fraction भी chronically down હશે most likely viability test કર્યો તો કદાચ there were may not be chances of improvement in area and post procedure કેટલા ટાઈમ છે આને
Almost 6 months.
તો પછીના ઇકો છે આપણી પાસે
એટલે અલ્ટિમેટલી પેશન્ટનું શું થયું ઇમ્પેલા નાખી દીધી ચાલ
indication is clearly કે young cardiologist sitting outside is an indication
outside भी नहीं US particularly US
high risk PCR હતી અને
High risk PCR
we were reluctant to do
મતલબ ટ્રોપોનિન વધારે નહોતા
એ પ્રોપોઈન્ટ મને યાદ નથી સાહેબ અત્યારે
પણ આ લોકો રિલેક્સન્ટ હતા એટલે સામેથી પેલા
હા એટલે એ સમયનો ડિસ્કસ એવો થયો હતો પુનીતભાઈનો અમારો કે આપણા તરફથી એટલું ઇન્સિસ્ટન્ટ હતું કે બહુ હાઈ રિસ્ક પીસીઆર છે એટલે ડ્યુરિંગ ઓન ટેબલ પર ડેથ થઈ શકે એમ એવું ડિસ્કશન આવ્યું અને પછી એ ડિસ્કશનમાં ઓન ટેબલ ડેથ પ્રિવેન્ટ કરવા માટે આપણે ટીપીએમ ટેમ્પરરી પેસમેકર ને ઇમ્પેલા નાખીને પછી પીસીઆઈ કરી દીધી વાત કે તમે ઇમ્પેલા કેમ ટ્રાય કરતા તમે જો એવું લાગતું હોય કે ઓન ટેબલ હાઈ
એટલે પછી થયું સક્સેસફુલી થયું
કેટલા દિવસ રાખેલો
પેલું ડિસ્ચાર્જ
ઇમ્પેલા કેટલા દિવસ રાખે તરત જ પ્રોસિજર વખતે જ રાખે.
Patient was less than 6 hours.
Less than 6 hours. For PCL it is less than
ઓછી વખતે પ્રોફાઇલિટી કરી નાખી પછી કાઢી
બરાબર છે પેલો કહેતો હોય તો સામે
અને મુંબઈમાં બહુ રૂટીનલી યુઝ થાય છે આપણે જો ગુજરાતમાં નથી યુઝ કરતા
રૂટીન તો આખા ભારતમાં ક્યાંય યુઝ નથી થતું મારી
આઈએબીપી વધારે સપોર્ટ નહીં કરતા હશે આઈએબીપી
મુંબઈમાં કરે છે એચએન રિલાયન્સમાં ને જે ટ્રાન્સપ્લાન્ટ યુનિટ છે
અત્યારે ઇન્ડિયામાં ટ્રાયલ સ્ટાર્ટ થયા હમણાં બરોબર છે બધા ટ્રાયલ છે કોઈ રૂટીનલી યુઝ કરવા વાળે તો અત્યારે ઇન્ડિયામાં
મહિનામાં એક
એન્ટ્રી
પેશન્ટ હોય જ છે એમની પાસે એચએન રિલાયન્સમાં અને એ લોકો બ્રિજ ટુ ટ્રાન્સપ્લાન્ટ મોસ્ટલી યુઝ કરે છે
for that it is fine.
કે આ પેશન્ટ ઇમ્પેલા લગાવે તો ઇમ્પેલા વાળા પેશન્ટને કમ્પેરેટિવલી હાર્ટ થોડું વેલ્યુ મળી જતું હોય છે આઈએમપી ઇકમો ઇમ્પેલા વાળું પેશન્ટ જે મિકેનિકલ સર્ક્યુલેટરી ડિવાઇસ વાળા પેશન્ટનો હાર્ટ ટ્રાન્સપ્લાન્ટમાં નંબર ઉપર આવી જાય છે એ લોકોનો મેઇન ગોલ હાર્ટ ટ્રાન્સપ્લાન્ટ નંબર વધારવાનો છે
પણ પહેલા એ તો 14 દિવસથી વધારે તમથી આપણે વાપરી નથી શકવાના 14 દિવસમાં હાર્ટ મળી જાય શક્યતા કેટલી બરાબર એટલે બાકીના ડિવાઇસીસ છે લોંગ ટર્મ યુઝ થાય VAD ઇઝ પ્રોબેબલ ગુડ ઓપ્શન બાકી ઇમ્પેલા ટ્રાન્સપ્લાન્ટ માટે ઠીક છે સાવ ઇમિનેટ
આ જાતો વીએડી થયું ને વેન્ટિક્યુલર આસિસ્ટેડ વીએડી થયું ને
અને આમાં બી બાય વેન્ટ્રિક્યુલર ફેલિયર હોય આરવી ફેલિયર હોય તો તમારો કોઈ ઓપ્શન નથી તમે યુઝ ના કરી શકો
બે બાજુ બે નહીં
હા એટલે બે વખત બે તો એના કરતા પછી ઇકો મૂકી દેવું પેશન્ટ એમ
RV માં બી
ઇકો પર મૂકી દેવું
તો પેશન્ટના બંને કાર્ડિયોલોજિસ્ટ હોવા જોઈએ સાહેબ
એટલે એમણે બે ત્રણ પેલા ઇન્ડિકેશનમાં કહ્યું હતું તો ખરું કે લેફ્ટ સાઈડ ઇમ્પેલા એટલે આરવી નું
RV માં બી
આવું
થતું હોય.
આરવી પેલા
હશે ને
RV પેલા છે but RV ને LV બંને
બે
પણ
ભેગું
સાથે
હોય
આવે.
એના કરતા પછી ઇકો
બંને એક્સેસ તમે વાપરી કાઢો તો વાર્તા પૂરી થઈ જાય
એના કરતા એક
ઇકો
નો
પર લઈ જાઓ
ICMO plus Impella is better.
તમે
required to actually make a significant change.
So the collection of the data, whether number of patients or your observation, they are not enough to draw a such statistically significant this thing, right? So that is underpowered. અને Impella શબ્દ જે આ impelier તમે શરૂઆતમાં કીધું હતું એનો મીનિંગ શું થાય? ઓ પહેલી સ્લાઇડ હતી ને જે એકદમ એમાં impelier કંઈક something like that. Impella.
It's like
It is
the motor.
the one who drives.
So impeller is basically a Latin word and a મતલબ થાય to push.
To pull and push. બ્લડને પુલ કરીને પછી આગળ પ્રેક્ટિકલી ફંક્શન કરે.
Pull from the lower to.
Just to push. ધક્કા ગાડી.
Rocket.
20 લાખની ધક્કા ગાડી.
20 હશે ને 20 જ ને સમય મને એક્ઝેક્ટલી હું તો બોલ્યો હતો.
So આ જે Impella critical expert મૂકે કે કાર્ડિયોલોજિસ્ટ મૂકે? કાર્ડિયોલોજિસ્ટ મૂકે.
ઇન્ટરવેન્શન